Good evening, ladies and gentlemen. My name is Jane Hughes and I work for the Hunterian Museum here at the Royal College of Surgeons. It's a great pleasure to welcome you all here this evening. The event Surgical Futures is part of the Mayor of London's Story of London Festival, which is going on all through this week. And for those of you that just don't get enough of the college this evening, we've also got free lunchtime talks looking at the history of surgical research and innovation in the 18th century going on every lunchtime from tomorrow until Friday. That's my quick plug over. Before I introduce our chair for this evening, Richard Hollingham, I'm just going to hand you over for a very short introduction by Johnny Fountain, who is the Development Director here at the Royal College of Surgeons.
Thank you very much. I'm what's commonly known as the warm-up act, or the commercial, I suppose. It's an old one. I'm just start saying, I do remember when Michael Howard was Home Secretary, and he used to do his prison visits, and he also used to start everything by saying, "How nice to see so many of you here." And it is very nice to see you all here. I'm really trying to put in context the three research speakers you're going to hear tonight in terms of the college. Just to start with, the college is obviously the professional body for surgery, but its primary purpose is to look after patients. It's not part of the NHS, and it guards its independence very, very strongly. The college today does a whole range of things, not just research, which we're going to come on to. In terms of education, we run 600 courses a year for 12,000 participants. We have a state-of-the-art facility on the fourth floor of this building, including a fully functioning operating theatre. We have a training department. We run examinations. We do a lot of media work and lobbying with government. And, of course, we have a fantastic museum, the Hunterian Museum. But the purpose of this evening is to look very quickly at research. Now, there are very, very few people who are not going to be touched by surgical research either directly or indirectly. And over the last 50 years, there has probably been no other area of research which has done more to reduce mortality and disease and to restore the quality of life for people. And this is things from heart and cancer surgery to hip and knee joint replacements. Now, it all started with John Hunter, who was the sort of A-list celebrity of his day. Now, he was the person that showed through demonstration and experimentation and observation that actually you could influence surgical practice and you could form that evidence base. And he's quite rightly known as the father of scientific surgery. When he died, his collection, his extensive teaching collection, was purchased by the government of the day and placed in 1799, placed in the care of the college. And that collection still forms the core of the Hunterian Museum today. The college has continued, and research is a central tenet of everything that the college stands for. It was conducted for many years under the auspices of the Hunterian Institute, with some significant results. We had a Nobel Prize winner and I think 2 Nobel laureates here. But back in the early 90s, people realized that research away from the universities and away from a clinical environment wasn't really very viable. And so there was a comprehensive review of the research that the college was sponsoring. And as a result of that, departments were either relocated or closed down. And in their place, we formed something called the Surgical Research Scheme with 3 main aims: to contribute to improvements in patient care and recovery, to assess new techniques in surgery, and to examine the causes of surgical conditions and how to treat them. Now, the surgical research fellowships are fairly unique in that what we're doing is bringing a clinician, somebody who treats patients, and joining them with a researcher. This is translational research, it's patient-focused. These are people who look at the diseases and injuries of patients they see at the bedside, and that's what interests them. It's a national scheme. We think it's a scheme of national importance. It's certainly been copied by other people. We give fellowships up and down the country, the length and breadth of the country, and we also do international awards as well. It's highly competitive. In the last round, there were 106 applications for research grants. We shortlisted 40 researchers, and we awarded after a pretty extensive peer review and interview process, 15 research fellowships. So the people you see tonight are hopefully the brightest and the best of their generation. And it's also quality assured. We don't just look at the researcher, we look at the department, we look at the supervisor, and we look at the research question to make sure that the money we're spending and the research that's taking place is worthwhile. Well, why does any of this matter? Well, surgery does save lives, as I said. 10% of cancers are cured by drugs, 50% are cured by surgery. And if you think of transplantation, trauma and injury through an A&E departments, age-related disabilities, and disfigurement, either congenital disfigurement or through injury or illness, surgery is providing some of the answers. But there is no doubt future innovation will be driven by research. But it's interesting to note that 35% of hospital care in this country is delivered surgically, and yet less than 2% of national research funding is spent on surgically based projects. There is a brighter future. Surgery, minimally accessed surgery through small incisions and natural body orifices is reducing infection rates, it's reducing trauma, it's reducing healing, and it's leading the way. Robotic surgery is allowing surgeons to remove cancers much more cleanly. Electrostimulation is allowing things like cochlear implants to restore hearing to the deaf. Laser technology is allowing bloodless cuts, and stem cell research is really a very, very exciting area which is going to help cancer, transplantation, blindness, and all sorts of other disease areas. But what's it cost? Well, each of these research fellowships costs about £50,000 a year. We have some endowed funds in the college, and when we first started this scheme, they covered most of the research grants that we gave. But those funds are simply not keeping pace with inflation or the costs of research. And so more and more we have to rely on external funders to fund this programme. In fact, we're not able to support 80% of those people applying for research funds, even though they meet the quality required. And each year we must raise in excess of £1.4 million just to keep this going. Well, I've called it the Hunter factor, or the X factor. Have we got the Hunter factor? Well, here's John Hunter's house, and let's have a look at them. The people in the front row, you must forgive me for this, but there they are, morphed. Well, how can you help? You can make a donation. You can try and help this scheme. There is a form on every chair, and if you'd like to consider making a contribution, that would be very, very gratefully received. You could leave a legacy, and of course, if you think you're up to it in the future, you can train to be a surgeon. There's more information on our website from everything I've talked about, but I'd say please help our operation be a success. And on that note, I'm going to hand you over to Jane, who's going to introduce the chairman.
Just briefly, this evening's chair is Richard Hollingham. He's a BBC current affairs presenter, an author and a journalist, and he specialises in science and the environment. He's reported from an Antarctic crevasse, a rocket launch pad in Kazakhstan, and from the wreckage site of a New York air crash. I listen to him frequently on Radio 4 because I'm getting old, but I do enjoy his reports. The From Our Own Correspondent is my particular favourite. But Richard, as well as being a media person, is also an author. He's written a great book called Blood and Guts, A History of Surgery, which was made into a BBC TV programme as well with Michael Mosley as the presenter. So Richard has a keen interest in the history and the modern practice of surgery. His book is described as a chronicle of stolen corpses, medical fraud, lobotomised patients, and every now and again, the courageous medical advances which have saved the lives of millions around the world. And it's the advances that are being made through surgical research that we're here to hear about this evening. So I'm going to hand over to Richard to introduce the speakers.
You don't have to applaud me, really, you don't. welcome. Thank you very much for coming this evening. I was just thinking, before we get on to some of the current advances, because some of the things that have happened to surgery in the last 50 years, and these are things we take for granted. Open heart surgery, transplant operations, I mean, they've only really been successful in the last 30 years. Microsurgery, and as Johnny mentioned, the robotic surgery. New surgical techniques are being developed all the time. And this evening we're going to get an insight into some fascinating research investigating 3 conditions that still have many surgeons stumped: cancer, stroke, and osteoarthritis. Now we're going to hear from each of our surgical research fellows in turn. As you heard, the best of the best, the brightest of the best. No pressure, guys. And then we'll have questions after all 3 presentations. So we're going to hear from Siobhan McKay from Imperial College London, who's working on the genetic basis of biliary cancer. Now, biliary cancer, I hadn't come across biliary cancer. It's cancer of the bile duct. It's a particularly devastating cancer. If you look it up, it's a particularly nasty one, and the number of cases is rising. We'll hear about that from Siobhan. Then we've got Joseph Shaloub of Imperial College as well. He's going to talk about a new ultrasound scan being developed to help predict and prevent strokes in patients with arterial disease in the carotid artery. I do know where that is. It's the artery in the neck that supplies blood to the brain. Pretty important. First, though, we're going to hear from Matthew Gardner from Imperial College. He's going to talk about his work investigating ways to prevent the development of osteoarthritis. Matthew.
Thank you very much for that very kind introduction. So I'm currently a plastic surgery research fellow at Imperial College, and my passion over the last 3.5 years now has been osteoarthritis. So I want to convince you today that it's an important disease to study, and that we are making some progress in trying to get to the bottom of it and work out how perhaps we can cure it. So it's common and it's high impact. If I was a betting man, which I'm not really, but I would say that all of you in this room today either have osteoarthritis, know someone who has osteoarthritis, or perhaps even have osteoarthritis but don't know that you have it yet. And more of that later on. In the UK, it's a significant problem. They estimate that over 70% of people over 65 have the disease. It costs over £900 million a year in joint replacement surgery alone. So it also costs the NHS a significant amount of money. Now, everyone thinks that osteoarthritis is a disease of the elderly, and to a degree, it is true that as people age, more people develop osteoarthritis. However, it's not just a disease of the elderly. There's an increasingly young population of patients who have osteoarthritis, and those patients perhaps have suffered joint injury, they've got instability in their joints, or perhaps their genetic makeup and other factors such as their weight and their mobility have affected their joints, and they're at increased risk of osteoarthritis. Now, this is a real problem because actually they may not be suitable for joint replacement surgery and some of the methods of treating the disease that we have. So what is osteoarthritis? Well, it's a disease of synovial joints. These joints include all your hand joints, your knee, hip, basically those joints where 2 bones come together. They have a lining of cartilage that forms a cushion at the end of each joint, and they're within a capsule. And in that capsule there's synovial fluid, which is a lubricant for the joint. Now, as osteoarthritis progresses, we have a loss of cartilage, the bone becomes deformed, you get these bony outgrowths called osteophytes. The bone, it becomes less of a shock absorber as well, and there may well be inflammation. Now, for patients, that equates to, for instance, in the hand, knobbly fingers. Here on the left, you can see a patient with osteoarthritis in the small joints of the hand. It can lead to pain, joint stiffness, and loss of function. And on the right is the X-ray, which also shows, if you look at the small joints of the hand, of the fingers up here, the joint spaces are destroyed, you can see the swelling, and that's likely to be a very painful hand. Now, diagnosis is usually on the symptoms that a patient might present with, as well as the X-ray that you can see here. So at the moment, there's no cure, only symptom relief. Modern medical science can only really offer painkillers and joint replacement surgery. Now, joint replacement surgery for end-stage disease has been incredibly successful. Around 60,000 joint replacements occur every year in the UK. And they're becoming better and better. They last longer, and you can be cleverer with these joint replacements. So, for instance, with this one here, only half of the joint is replaced, so the side that is really affected by the osteoarthritis, and we can leave the other side that's sort of more normal and doesn't actually need the joint replacement. Osteoarthritis is a real research challenge. We have a disease that causes slow, progressive degeneration within a joint. It tends to start around the age of 40, but you may not actually present as a patient until you're in your 60s, 70s perhaps. So from a point of view of studying it as a disease, it's very difficult. Also, the state of your joints doesn't necessarily correlate to your symptoms. So for instance, you can have a really degenerated joint that on an X-ray, as this one shows, is really quite destroyed, yet actually not have any pain and little disability. This is a replacement of a knee. You can see this is the end of the femur and the tibia here with the patella replacement here. Now, this is an end-stage disease, and we can access and take cartilage at that time point, yet the cartilage we get from that point of view is really degraded and it's old. But what we really want to do is know what's going on right at the very start of the disease. To do that, though, we have to try and look at the structure of cartilage first of all, and I'll try and run through this quite quickly. Why does cartilage degrade? But we need to know the structure. So the most important point is the interaction between the only cell type in cartilage, which is the chondrocyte here, and I've got all these kind of strands around it, but really that is the extracellular matrix, the scaffolding, if you like, in which these cells sit. And within the collagen scaffold, there's this kind of hard jelly-like substance that gives the cushioning effect to the cartilage. Now, in normal cartilage, there's an equilibrium. The cells produce enzymes that break down the cartilage, but the cells also produce new cartilage. And this is balanced. In osteoarthritis, though, we think this becomes unbalanced, and more enzymes are created to sort of degrade the cartilage than protect it. So my research has focused on using an animal model to look at the progression of osteoarthritis. Now, we can't study it in humans because, as I said, access to the cartilage is only really at the very end stage of disease. I don't think any of you would probably stand up and volunteer to have an operation to have your cartilage removed. So unfortunately, we have to look elsewhere, and in this case, we have a mouse model. We do a very small surgical operation to the knee joint, and we destabilize this meniscus. Now, the meniscus is a small piece of cartilage that sits in your knee joint and acts as an additional cushion to loads. By destabilizing the joint, the mouse develops osteoarthritis, and as you can see, this is a normal joint. You have a nice, smooth, articular surface here. It looks very healthy. And over the course of 4 to 8 weeks, it gradually degrades until you've almost lost all of the cartilage here. So we're looking at two things, really. We want to look at the gene expression, how these chondrocytes convert the information they hold into the proteins. Now, to do that, we need to actually get hold of these chondrocytes and try and get them from the cartilage. And I've applied a new technique called laser microdissection. We take the mouse knee joint, we chop it up, and we stain it. And then using a laser microscope, we can individually take the cells. Now, hopefully this will work. So what you can see here are the two articular surfaces. This is all cartilage here. And we're just zooming in now to times 40 magnification. So these chondrocytes are very, very small. And you can see the individual chondrocytes sitting in the cartilage. This purple stuff around it is the matrix. It's the kind of hard jelly that gives cartilage its cushioning property. And using a mouse on a screen, I can select the individual chondrocytes and then, sorry, this is slightly slow, then blast them into an Eppendorf and capture the individual cells. Now, why this is so important is that osteoarthritis develops as small lesions within your joint in different areas, and we really want to be able to capture the chondrocytes, the cells that are near those lesions, to see what they're actually doing. So here you can see a laser is firing the individual cells into a cap, and once we've captured the cells, we can then analyze them to see what the genetic information is in them. Now, you can fire at individual cells, and we can also cut out areas of tissue that we're particularly interested in. So this is an example now of me drawing a random shape to select some of the cells. Now, this genetic information that we can capture from the chondrocytes is used to code which proteins the cell should make. And I'll come on to trying to look at the protein profile as well in a second. So here the laser is now cutting through this matrix, and we've selected these cells here that we're particularly interested in. I think we've had enough of that. So the chondrocytes have this genetic information in them, and they can translate that into actual proteins, so producing this matrix that sits in the cartilage. And this is some work where I've microdissected the cartilage from the knee joint and then extracted the proteins from the cartilage. I can then separate them and fluorescently label them. I can take them from normal joints and diseased joints, and they're each labeled with different fluorescent dyes, a red one and a green one. Now, these are merged images, so if there's no difference between normal and disease, it looks yellow. And as you can see, at 2 weeks, when I take the cartilage, it looks normal. Okay, there's no difference, it's yellow. At 4 weeks, there seem to be a few differences in these proteins, and by 8 weeks, you can see these red dots and very, very bright green dots, and so there's definitely been some changes. And really, by combining the genetic information, the protein changes, we can try and understand what's happening during the progression of osteoarthritis. Now, in the laboratory, we've developed a mouse that you can genetically alter so that one of the key enzymes in protecting the cartilage has a different amino acid tagged to it, and this means that the mouse actually protects its cartilage. So you can do this operation, and it doesn't go on to develop osteoarthritis. And we've now developed a new mouse that can actually switch on this particularly modified enzyme when you inject a certain drug. So this enzyme is then only produced in the cartilage. Although you're giving it to them systemically, the drug, it will only turn on in the cartilage, so not in the muscle, not in bones or elsewhere. And we can apply these genetic and proteomic approaches to work out the differences between this genetic mouse that we've engineered and the normal mice. So where's this all leading to? Well, it's improving our understanding of what happens during osteoarthritis, what is the initial trigger, why the disease actually forms in the first place. We're able to identify targets for treatment, and this enzyme that I've mentioned, it's called TIMP3, for any of you matrix biologists out there. It is so important, and it's a target for treating the disease. And finally, at the moment, we can only diagnose osteoarthritis with the symptoms of a patient and an X-ray, really. But perhaps if we were able to take blood samples or urine samples, we could diagnose patients much earlier, treat them much earlier, and perhaps monitor the progression of the disease. So the future's bright. Finally, I'd like to thank the Royal College of Surgeons. This research wouldn't be possible without the Research Fellowship Scheme. In particular, I'd like to thank the Freemasons who sponsored my particular fellowship, my supervisors, Hideaki Nagazi and Jagdeep Nanchahal at the Kennedy Institute of Rheumatology. And this work is done at Imperial College and is also supported by the Kennedy Institute of Rheumatology. Thank you very much.
I'm sure you've all got questions. I want you to keep your questions in your mind until we've heard from other two speakers. The next person to speak is Joseph Shaloub, again from Imperial College London. Is going to talk about a new ultrasound scan being developed to help predict and, crucially, prevent strokes. Oh. Are you next then? Okay. Okay, well, let's have Siobhan next, shall we? So, this is completely my fault. Siobhan, again from Imperial College London, are working on the genetic basis of biliary cancer.
Hi everyone. I've titled my talk Unravelling the Code of Biliary Cancer because, as Richard kindly said, it's looking at DNA and then trying to understand what's happened and what we can then change in cancer for treatment, diagnosis and prognosis. So just briefly, just on a very simplistic level to explain how cancer's formed. What I'm just showing here diagrammatically is a normal cell. Looks nice, looks completely normal. And what you have with cancer is a cell that does things normally, like it grows and it dies. In cancer, it doesn't do those things normally. So it has its normal functions acting abnormally. And what happens is you have uncontrolled cell growth, because every cell's supposed to grow, but what happens is it doesn't die when it's supposed to. And crucially, it invades other tissues, and that's where we get the problems. So this happens through various mutations of these processes. So your normal genes, which cause your cell to grow, become mutated, and it grows more than it should. You get further mutations, and the genes which normally make the cell die no longer make it die. And this gives you a rather ugly cancer cell here, which is not looking nice and clean like this cell here. It's invading into other tissues. It's got all sorts of abnormal nuclei, and that's one of the hallmarks of cancer. So we can look at these DNA changes, the gains of the growing genes and the losses of the death genes, to try and find targets for treatment in cancer. We can also use these maps of changes in the DNA to try and predict who's going to do well and who's not going to do well with cancer, and also to try and find kind of early diagnostic tests to be able to see who's got the cancer earlier so we can have more patients who can be having curative operations. So obviously cancer is a rather broad topic, and I'm looking at something rather specific because my interest is in liver surgery, and the cancer that I look at is of the biliary tract. So just to give you a little run through the anatomy, this is within the abdomen. So here's the esophagus, which leads to the stomach, and then onto the small bowel, and nestling in the small bowel there is the pancreas. And then you have the liver, which forms bile, and then all within the liver, bile is produced, and tiny cells lining the bile ducts form up to make these big biliary tubes. And it's the cancer of the biliary tract is within the whole liver substance itself, and also within these tubes which come down to deposit bile within the bowel. So why is this cancer that no one's ever heard of important? Well, it's important because it's been increasing in incidence considerably over the last 3 decades. There's actually, just within this slide itself, which as you can see is only up until the late 90s, it had increased 165% within the UK over this time period. So it's becoming an increasing disease burden. And now within the UK, biliary cancer represents the highest cause of mortality from primary liver cancer. Not only is it becoming increasingly important because more patients are developing it, it's got a dismal clinical course. For every 100 patients that present with biliary cancer, only 20 of those will be surgically operable at presentation. And of those 20 that are able to have an operation, only 5 patients of those will be alive 5 years on. So we've got a quarter of patients that can have the operation are alive after 5 years. But for the 80 patients which aren't able to have an operation because their cancer is too large or spread to other places, they have the option of only medical therapy, such as chemotherapy or radiotherapy. And unfortunately, only 3 of those patients will be alive for 5 years later. So if patients are able to have a curative operation, we'll have 25% of those will be alive 5 years later. If they're not able to have a curative operation, only 4% of them will be alive 5 years later. So it's very important that we can make more people into the operable group so we can cure more of these patients of this cancer. And this is not projected very well, but Henri Bismuth, a French surgeon, a very famous French liver surgeon, who was treating bowel cancer which had spread to the liver showed in the 90s that if you gave effective medical treatment to these inoperable cancers in the liver, you could shrink the tumour down to a size that it could then be operated on, and these patients could have a cure, similar to the cure rate if you presented initially with an operable tumour. So this is what we're trying to achieve. So the aim of my study is to identify molecular targets in biliary cancer, so we can use targeted treatment to effectively shrink the cancer and increase the proportion of patients who can have a curative operation. So a jazzy title is a magic bullet for biliary cancer, because we're trying to identify these molecular targets which we found from our DNA studies. So I apologise for the confusing slide, but I'll just walk you through it. So the technique that we've used to look at the DNA changes is called comparative genomic hybridization. And what this does is it looks at a very kind of broad way at the gains and the losses, so the extra oncogenes, or the genes that cause the tumour to grow, and the losses of the tumour suppressor genes that cause it not to die. So we take the tumour DNA and we chop it up, and then we label it with this green fluorescent probe. And we take normal DNA and we chop it up, and we label it with a red fluorescent probe. Then we stick it all together on this array slide, and what this array slide has is the whole human genome chopped up into tiny little bits all along here and stuck down onto the slide. So the tumour DNA and the normal DNA find the spot on the slide that corresponds to that area of the DNA chain, and then we scan the fluorescence. And this is a picture here of one of my fluorescence scans. And what you're seeing is lots of yellow, red, and green dots. And a very clever computer tells me exactly where they are and what they mean. So if you look down here, just to explain what actually happens, the amount of normal DNA is always the same. So that's in red. So we always have the same amount of red fluorescence. But what we have is variations in the amount of green fluorescence, which is the tumour DNA. So if we gained areas of DNA, because we've got extra of these genes from the mutations, we have more of the green fluorescence, so there's more green than the red, and that shows up as a green spot here on our array. If we've lost DNA in the tumour because there's been deletions of genes, we have less of the green fluorescence, so you see more of the red, and this shows up as a red spot. What then happens is we then put this into a clever computer program that tells us exactly where along the DNA change in all of the 23 pairs of chromosomes this alteration is, down to the exact base pair number, and we can then say what genes are in that region and what is altered. So this is a summary of all the DNA changes that I've looked at so far in my 32 cases of the biliary cancer. And what you've got at the top here, these are the regions of gain in green, and these are the regions of loss in red. And along the bottom is the chromosomes in pairs 1 to 23. So you can, for instance, see that there's a loss here on chromosome 1. There's a gain here on chromosome 17. So overall, we had 89 regions of gain, we had 55 regions of loss, and 6 regions of gain were in all cases. But what does that actually mean? So if we look in a bit more depth at a region on chromosome 17, and this small region we found to be gained in all our cases of biliary cancer, we can plug this region into the database from the Human Genome Project helped develop, and we can look in more detail and we see all these genes along here are within this region that's gained. So we have to decide what is the important gene then to study, because we've thrown up hundreds and hundreds of genes. So we relate them to important biological processes, and this brought up this gene here, B2, and this is also known as HER2. And this is an important gene because this is what's been targeted in breast cancer since the late 1980s, early 1990s with Herceptin. And patients who have overexpression or amplification of the HER2 gene have excellent results with Herceptin. And this isn't something we necessarily expected in biliary cancer. So we found that all my cases that I've studied thus far have this region gained. So it's likely that a fair proportion of these will actually translate into an amplification of this region. So it's very possible that this will be a very effective treatment in these patients. We've also found these other 4 genes which have known already developed agents which are used in other cancers. So this has been a very useful technique to kind of fast forward which drugs we'll be able to use. Another outcome of the study is that we've been able to look at predicting who's going to do well and who's not going to do well in regards to prognosis. So these are two survival plots, and what we found in analysing our data is that we found two specific regions within chromosome 13 and chromosome 11, which, if altered, relate to survival. And you can see on the chromosome 3 here, this group are in the good survival group. They don't have the alteration in this region, and these ones are in the poor group, and along the bottom is the months. So if you don't have the alteration in your DNA on chromosome 3 at this specific point, you're likely to have good survival and survive. And on average terms, the median survival in this group is about 40 months. But if you do have this alteration, your median survival is 10 months. Now, that's really key for a patient to know, because we're going to give them very aggressive treatments, and they would want to know what is the likelihood of success and how long am I going to, what's the best chance that I'll be here. So it's really key that we're able to give better information to our patients so they can make more treatment choices about what they want. So in summary, my study thus far has mapped the DNA regions that are gained and lost in biliary cancer. We've identified genes that can be treated with targeted molecular agents which are already in use for other cancers worldwide. And if we can use these effectively in biliary cancer, we'd hopefully increase the number of patients which we're able to offer a curative operation to. And we've also identified 2 DNA changes which are linked to good and poor survival. So these are very exciting changes that we found, first group in the world, and so we've got to validate this and take this forward, but we're really quite excited about this. So I'd like to thank the Royal College for funding it and also my other funding bodies. And research is never a solo effort. No one does it alone. I've had a lot of help during my PhD, so I'd like to thank all the groups that have helped me and held my hand along the way. Thank you.
Again, save your questions to the end. And now it's time for Joseph.
Just while the slides are coming up, I'd like to thank the Royal College of Surgeons for the invitation to speak at this exciting event. My name's Joseph Shalhoub. I'm a surgical trainee with an interest in vascular surgery. And my research, which has been funded by the college, is looking towards predicting stroke. So what's this all about? I'm sure you're familiar with the FAST campaign, which is a campaign by the government to improve awareness about stroke. Stroke is a very important condition, and it can affect both the physical attributes of an individual, but it can also affect their personality. And so one of the highlights of the campaign is by improving awareness about the condition. If you have changes in your face, drooping on one side, problems with your arms or your legs, speech difficulties, either slurring or speech, or difficulty finding words, then it's time to call, because the sooner you call, the sooner you can get treatment, and the more of that person you'll be able to save. An important analogy of a stroke is with a heart attack. When oxygen and blood supply to the heart is reduced, then you can get a heart attack. In the same way, if the blood supply to the brain is reduced, then you can get what's called a brain attack or a stroke. So the burden of stroke is very high. It's the 3rd leading cause of death in the UK, and a major cause of disability, but also dependence, reliance on others among UK adults. And it's a huge and rising health economic burden. So much so that there's been centralisation of care within the UK of stroke services. And this is a good example, focusing on London, of the stroke centres which have arisen in the past few years. And I'll draw your attention to the pink spots, which have been designated as hyperacute stroke units for the treatment of stroke as soon as it arises, with special therapies such as clot-busting drugs to try to prevent patients from having long-term consequences of limitation of blood supply to the brain. Well, moving on to my area of research, which is the carotid artery. The carotid artery is an artery in the neck. There's one on either side of the neck, and it supplies blood to the brain. This is responsible for about 20% of stroke. What makes a carotid artery likely to give someone a stroke is the development of narrowing in the carotid artery in the side which supplies blood to the brain, which is this side here. And you can see there's a build-up of diseased material in the artery between the heart, which will be down here, and the brain. Some patients who have strokes have a mini stroke as a warning sign that they'll have a bigger stroke later on. And about a quarter of patients will experience a mini stroke before they have a big stroke. And there is surgery to prevent these patients from going on to develop a stroke. And this is well supported by evidence. So the operation which we're describing to prevent strokes in these individuals involves making a cut in the neck over the artery. This can be done with the patient either awake or asleep. You then remove the area of narrowing from the artery, and then you close the artery afterwards, leaving a nice, healthy, clean, open artery with no impingement of blood supply to the brain. So what's occurred is there's increased stroke awareness, the development of stroke centres, and lots of patients are having carotid artery scans on their neck. Patients who've got heart disease have the same kind of condition as the carotid artery disease elsewhere in their body. Similarly, there's individuals who've got narrowings in the arteries in their legs, and it's again the same disease process causing narrowing in these arteries. So if patients have heart disease or narrowings in the arteries to their legs, again, they'll be put forward for a scan of the arteries in their neck. And as a consequence, we're doing lots and lots of carotid scans on patients. And we're identifying lots of patients with carotid disease. But similarly, these patients don't have any warning signs. So we're identifying lots of patients with carotid disease who don't have warning signs, i.e. they don't have a mini stroke before they have a major stroke. And about 10,000 people in the UK have narrowing in their carotid artery in their neck, but haven't had any warning signs that we know of. And there are a number of individuals who have this narrowing who don't know that they have this narrowing. So this is an example of a diagrammatic representation of a carotid scan. And this patient on the left-hand side of their neck has a narrowing of 85% in their carotid artery. But they haven't had any warning signs. The evidence is there to operate on these patients if they've had a mini stroke before. But if they haven't, we don't really know what to do. Of those who don't have warning signs, about 1 in 10 will have a stroke in the next 5 years. But if all had surgery, 9 out of 10 wouldn't benefit from that operation. And that operation does carry a risk. So it's a balance between preventing stroke and preventing unnecessary operations. But as I said before, a quarter of these patients have warning signs, but 3/4 don't have a warning sign and don't have a mini stroke before they have their big stroke. Therefore, you're very likely to be completely free of any symptoms the day before you have a stroke. So to operate or not to operate, it's a great and ongoing debate. And actually, this was the subject of a recent transatlantic debate in our journal, the Journal of Vascular Surgery. But what about the general medical press? Well, last month, there was a debate in the British Medical Journal, which is has quite a broad readership. And there was a group who said, yes, we should operate on all of these patients. And there was another group saying, no, we shouldn't operate on any of those patients. So is it yes or no? Well, we think there's a better way. We think the best way to do it is to select those patients who have narrowing, who don't have warning signs, who we think are at the highest risk of having stroke, and then selectively intervene on those individuals and do the operation that I described. So in order to be able to do that, we need to know what makes someone with a carotid disease likely to have a stroke. And so this is a picture of a carotid artery around here, and the disease is shown in this kind of odd lime green colour. And the two things which make an artery likely to cause a stroke are the presence of inflammation. So these cells, blue cells here called macrophages, and also the development of lots of tiny little blood vessels which grow in from the edge of the main blood vessel here, growing into the area of disease. And the more of these tiny little blood vessels there are, the more likely you are of developing a stroke in the future. So we're trying to develop scans to detect these biological features. So one of the scans we've developed is a scan called a PET scan, which is represented in this middle row here. This is a CAT scan, which tells us about the location of what we're looking at and gives us a roadmap of where it is we're actually looking. This is the PET scan here. And what the PET scan does is shows hot spots and cold spots. And the hot spots refer to inflammation. And where there's cold spots, blue, there's no inflammation. So if we look at the neck in the area where the carotid artery is here, on either side of the neck, or here at the side, you can see there's the main carotid artery branching to the blood supply to the brain. These pictures are overlaid so we're able to see. And in the area of the carotid artery, there's no hot spot at all. So we think that this patient with carotid narrowing is probably not going to have a stroke and therefore doesn't warrant intervention. Whereas if you look at this patient, you can see this is the carotid artery supplying the brain here. And if you look at the PET scan, you can see there's a big flare. And if you put the pictures together, you can see that the flare corresponds directly with the area of narrowing. So we believe that someone like this is likely to go on to have a stroke and therefore would warrant surgery. The final area that we're looking at is something called microbubbles. Microbubbles are tiny little bubbles which are engineered to be the same size as the red blood cells which carry the oxygen around your body. You can inject them into a vein into the arm, and they're able to enter the carotid artery disease by making their way into these tiny blood vessels which go into the disease. So this is a picture of our team doing a scan. We inject the microbubbles into a vein into the patient's arm, and we do an ultrasound scan similar to the scans which a expectant mother might have, and we're able to visualize the microbubbles going into the narrowing in the carotid artery. So the microbubbles which I described show up really, really brightly on ultrasound. They sparkle in this gold color. And here you can see the carotid artery going up to the brain here. Here's the area of narrowing, and you can see there's microbubbles inside the area of disease, and we're able to measure this. So this is a video describing that. So this is a normal ultrasound scan. This is the carotid artery, and this is the area of narrowing here, which you can just about see. Whereas if you look at the microbubble ultrasound scan, you can see the carotid artery again. Here's the area of narrowing, which you can see in black. And the microbubbles show up very, very brightly in this gold color. Then the outline of the artery is seen. But what you can also see, if you focus one more time on the area of disease, you can see the microbubbles coming in to the area of disease. There. So they light up the plaque. And what we're able to do is we're able to draw an area of interest around the artery itself, and also the area of interest around the area of disease. And so the yellow, you can see the amount of bubbles going up in the artery to a peak. And again, if you follow the red line, it shows how many bubbles there are in the area of disease. And that goes up to a peak. If you divide one of those by the other, then you can draw a graph. And we're able to see that those patients who've had a stroke have many, many more bubbles going into their area of disease than those who haven't had a stroke. And this difference is quite significant. If you wait 6 minutes and you look at the artery after that time period, you'll be able to see that there's very few microbubbles actually in the artery itself. If you remember on the previous pictures, this was bright, bright yellow, full of bubbles. And there was hardly any bubbles within the area of disease. Whereas at 6 minutes, lots of the bubbles have actually stuck to the disease, which was something that had never been seen before. So what we did was we measured at 6 minutes the number of bubbles which there were in the disease, compared it with the number of bubbles there were in the artery. And we found that if you've got more bubbles in your area of disease than in the artery at 6 minutes, you are very likely to have a stroke. If you had more bubbles within your artery than in your disease, i.e. the other way around, you are very unlikely to have a stroke. Well, what does this mean? Well, we took a piece of disease which we got at the time of the operation, and we stained it for a particular type of cell, the macrophage, which I described to you earlier, which indicates inflammation. And we're able to show that the more bubbles which stuck to the area of disease, the more likely you were to have inflammation in your artery. So what we were actually detecting using this scan was inflammation. So can a microbubble ultrasound actually predict which patients will go on to have a stroke? Well, the Royal College of Surgeons is actually funding my successor to answer this very question. So we're undertaking a study called contrast ultrasound or microbubble ultrasound for stroke prediction. And we're following 750 patients who have narrowing in their carotid artery, disease in their carotid artery, but don't have any warning signs, and following them up for 5 years to see whether or not they develop a stroke. And then tying back whether or not they had a stroke to their scan result when they originally entered the study. So in summary, preventing stroke is an important health strategy. There's an enduring need to develop ways to predict stroke in patients with carotid disease in whom there are no warning signs. And microbubble ultrasound shows promise and is under investigation in a large study. So I'd like to thank particularly the Royal College of Surgeons and the Rose Trees Trust who have funded the large majority of this research. The other funding organisations and my supervisors. Thank you very much.
So what I'm going to ask Matthew and Siobhan and Joe to do is just take a seat out here and take some questions now. And I've got a question for, well, I think I've got a question for everyone, actually. I'll start with you, Matthew, and I'll come and sit down in a second as well. Your work with osteoarthritis, I mean, and it's fascinating and it's scary, and I think, well, I'm probably going to get it, and my dodgy knee is that osteoarthritis at the moment. What point does this translate into treatments?
My research is, I would say, at the fairly early stage. So with most of this translational research, you see a problem in clinic. You might then take that problem back to the laboratory and do some preliminary experiments, and then try and investigate further and develop ways of treating the disease, or as these guys have shown, perhaps trying to diagnose it more easily, and then that eventually works its way back into the clinic with a drug or some form of intervention. So this is really identifying treatment targets. As I mentioned, we have an enzyme that looks interesting, and we could target that, and by inhibiting it, we may be able to prevent the osteoarthritis. But it's certainly a few years off at the moment. Yeah.
And I have a question for Siobhan as well. Am I allowed to have questions first? Is that fair? With biliary cancer, I mean, I'd never heard of it before. Will this, because it strikes me that the key thing here is you need earlier diagnosis. Mm-hmm. Is that right? Just because those shocking mortality rates, shocking death rates from it.
Yeah, it's although I'm excited by my research, likely the thing that will make the biggest difference is diagnosing it earlier, because maybe I shouldn't do that. Is because then, you know, if the cancer's diagnosed when it's a smaller, we'll be able to operate on more of them. So hopefully this will also identify DNA alterations that we can follow up to see if there's something we could look for in a blood test that we could then use as some kind of screening tool. But that, you know, as with Matt, is something that's along the line and way off. But that's certainly an aim of the research.
And I suppose my question to Joe is very similar. I saw your timeline at the end. You had sort of 2015, and this is more research. But this looks extremely promising. I mean, how does the process work in terms of getting this accepted?
We've been fortunate that we've received all the ethical approval that's required to actually undertake this study, and a lot of the funding which we need to complete this study has been attained, although we're looking for more funding to make sure that our follow-up all the way up to 5 years is secure. But once we confirm the ability of the microbubble ultrasound to predict whether these patients will go on to develop a stroke or not, we then need to set a level, how many bubbles going into the area of disease do we need to identify before we do an operation. So if we say you need to have 4 bubbles going into your area of disease before we do an operation, then we need to do another study to actually see, by setting that cut-off point, does that actually reduce the number of strokes and deaths which is occurring. So,
So you're literally counting bubbles?
Yes. To put it in simple terms, yes. It requires a lot of sophisticated software to do so, but what a lot of groups around the world have done is eyeballed it and see that there's lots of bubbles, few bubbles, no bubbles, but bubbles in a particular area. But what they've not managed to do in the past is actually ascribe a number to that. And by ascribing a number, it allows us to be able to select which patients have the more or less bubbles based on a threshold.
Okay, so there are a few thoughts to be getting on with. What I would do, if you've got a question, if you can just wait for the microphone to come to you before you ask it, because we're recording this and we want to hear your thoughts. So let's go for the first one bang in the middle, this chap here.
Brilliant. Hello. Yeah, there we go. Hi, this is actually mostly to Joe there. It's, one thing was why the carotid site? Why that's a site? Obviously, with strokes, I understand the connection, but why there's a build-up of plaque in that particular site?
That's a question which we've been trying to answer for a long time. We know that you get areas of disease where you get branches from a big artery into 2 smaller branches, because the way the blood's physics happens, so you get different types of stress as the blood flows through the artery. And sometimes if you have a specific pattern of stress against the artery wall, particularly when you get a division from 1 vessel into 2, then you can get a build-up of disease. So a carotid artery is one of a number of examples of that phenomenon.
Would this work with other arteries then?
It would work with other arteries, but the arteries have to be accessible and they can't move too much. So a good example would be to use the heart. People use microbubbles in the heart to look at the actual heart's tissue itself, not the blood vessels within the heart. The blood vessels within the heart are very small, they're very deep inside the chest, and also because the heart moves a lot, then the blood vessels will also move. So it'd be quite difficult to track the bubbles as they move. You get lots of blurring. Although the carotid artery pulsates, there's not a lot of movement.
Okay, let's have another question. This gentleman here in the 4th row.
Thank you. Is the sound coming up? Yes.
Trust the technology, it works.
I'm from Rose Trees Trust, so this is for Joe. I understand that 25% have a mini stroke, so you know they're at risk. How are you going to find the 75% of the rest? Are you going to give everyone a test, or you can narrow it down without testing everyone?
Those who've had a mini stroke, they don't need to have the scan which we've shown, because the evidence is there that we need to intervene on these individuals very quickly. So they're the ones who go forward for an operation, hopefully within 48 hours. For those that don't have a mini stroke, there's lots of mechanisms by which these patients are identified. And actually we're identifying lots and lots and lots and lots of these patients who haven't had a mini stroke, who we're not sure whether to operate on them or whether operating on them will do more harm than good. And this is why we need to select those who have the narrowing, which we know are there. We have these patients. But we don't want to operate on all of them because inevitably you're likely to cause more strokes than you prevent because it's a bit of a numbers game. But it's all about selecting the right patients, and the right patients are the ones who are likely to have a stroke. So you can give them an operation to then prevent that stroke.
What would you alert them to those people in the first place?
Lots of patients have heart disease, so they might have had a heart attack, high blood pressure, high cholesterol. They have those risk factors, and they get given a carotid scan. The carotid scan is quite built into the healthcare system at the moment. Similarly, lots of patients get pains in their legs when they walk, which are attributed to arterial disease in the legs. So if the patient has heart disease or leg disease, and they come to us for the disease in the leg, for example, we often then refer them on to have a scan of the neck, where we find sometimes patients who've got this narrowing, but they haven't had any symptoms in there of strokes or mini strokes from that.
Joe, is there lots of unnecessary surgery then at the moment?
I don't think there's unnecessary surgery. The reason why we select these patients very carefully for surgery if they don't have warning signs is because what we don't want to do is leave patients with carotid artery narrowing if there is a chance that they will go on to have a stroke. The question is very, very difficult, and it's a balance of risk. So each patient is taken on a very patient-by-patient basis at the moment. It's discussed in a multidisciplinary team meeting with neurologists, vascular surgeons, and X-ray doctors. They look at the scans which are available, which tell you how much narrowing there is there, but not how active those narrowings are, not how hot those narrowings are, just whether they're there or not.
So at the moment it's a sort of judgment call by committee, really, of whether to operate or not.
It's slightly more sophisticated
Obviously it's
than
more
that.
sophisticated.
You need to consider, because the risk of stroke is given according to a certain time point. So based on information X, Y, and Z, you are likely to have a stroke in the next X years. So we have that information. We have to then see, based on the patient's other medical issues, whether they are likely to survive the X years which we've said they might have a stroke within, and then also consider what their risk of having an operation is. Is their heart strong enough to have an operation? What we don't want to do is do an operation to prevent them from having a stroke, but give them a heart attack. It's something which people have wrestled with for a long time and have made lots and lots of forward movement. But what we want to try to do is give these people who make the decisions as much information as possible.
Okay, let's have some more questions. The lady, the white top in the middle there, excellent. Okay, don't trust the technology.
Okay. Why do you think there's been an increase in biliary cancer?
I think there's lots of different reasons behind that, as with everything. There's clear risk factors known in other parts of the world. For example, in Southeast Asia, it's the majority of cases of biliary cancer are linked to liver fluke infestation and eating particularly toxic fish. Well, we know that's not the problem in the UK. We don't have, I'm not aware of a particularly toxic fish, and we don't have an endemic of liver flukes. So there's not a clear story for explaining why biliary cancer has increased so spectacularly in the last 30 years. There's lots of theories. It's theorised that the increase in obesity has been a massive cause of the rise of biliary cancer, also in the US and in the UK and the rest of Western Europe. There's also some theories that hepatitis levels, which are not necessarily so high in the UK, but are quite high in America and very high in places such as Turkey and Egypt, They think that's possibly a cause. They've also linked alcohol, but I think it's a case of linking lots of things that seem to damage the liver, but there's not anything clearly pinned down at this point that we quite know what the cause of it is.
Okay, let's have another question. Yes, this gentleman here.
Hi there. You've got some very strong correlations with those two chromosome mutations, but I think you mentioned you only followed 36 patients. How many more patients do you think you'll need to follow to get some really statistically significant results?
We're going to include 75 cases in our initial study, and we're at the point of completing that. The reason for selecting that many patients is twofold. One is because it is quite a rare tumour, so it's actually been quite a struggle to get enough patients within the study itself. And second is funding also, which you don't really want to admit, but that's one of the cases that it's quite an expensive technique to do. So we're looking for trends, and then depending on the strength of the changes, if they're very significant changes, then that in itself you can then take that further and validate within a different set, and that's enough to know that, yeah, it's only 75 cases, but if the change is strong enough and significant enough, that is enough, as long as we validate it in something else. If the change isn't as significant and it's just more of a trend, then we'll have to broaden the study. But at this point, certainly the alteration on chromosome 3 is very strong.
I mean, anyone diagnosed with biliary cancer, I mean, it's going to be pretty scary, isn't it? Are they aware of those sort of the figures for mortality at the moment?
Yeah, it's well documented, and obviously they'll sit down, they'll have a discussion with the surgeon and also with the oncologist, and they'll make it quite clear what the outlook is. And unfortunately, it is very dismal at the moment, and it is very disappointing. But for those that are offered surgery, they've got a hope.
Okay, let's have another question. Is there one at the back at all? Yes, there is.
In terms of osteoporosis, is there anything you can do to prevent it? Diet, Pilates, stretching, or are you saying wait for an enzyme to come? Things like that. In terms of being someone who's 30, 40, and even someone who's maybe 70, who's had knee replacements, would you recommend stretching and dietary changes and so forth?
Well, certainly physiotherapy and continued exercise is a good thing. You probably, if you read the papers and you look on the web, there'll be lots of different dietary supplements that are supposedly good at treating osteoarthritis. So, for instance, glucosamine, chondroitin. I've seen people suggesting that boiling up chicken combs is a good idea as well.
And doing what with them?
Boiling them up and drinking the soup.
Okay.
Which is fine. It's not dangerous. But it may not improve your osteoarthritis. And there's actually relatively little evidence for these dietary supplements. They won't do you harm, but people have investigated these, they're looking at various types of osteoarthritis. And so really I think the advice is to stay fit, don't play professional football or rugby. It's estimated that approximately 50% of professional footballers retire with osteoarthritis. Lose weight if you're overweight. Obesity is certainly linked to osteoarthritis. But at the moment, really, as I said in my talk, unfortunately there isn't a cure. So if you develop it before it gets to the really end stage, then you really have to take painkillers and exercise.
You're not a professional footballer, are you?
Yeah. But some people find that these dietary supplements do help them. For instance, glucosamine. And I think the general advice is try taking it, and if you find that your disease improves, then continue. If it doesn't, don't keep paying however much it is a week to buy these pills. Yeah.
Do you think it's been neglected because it is, as you said at the beginning, it's old people's disease?
Or
perception as an old people's disease?
The perception was that it was a sort of wear and tear disease. It was just inevitable. If you get old, your joints are going to fall to bits. But really, as we know more about OA, that's just not the case. And I think really the reason that it gets neglected, it's not very sexy. It doesn't kill you. You might be in a whole lot of pain and not be able to do your daily things, but it's not going to kill you, unlike cancer. So that's why Siobhan gets all the money and I don't.
Well, it sounds like she doesn't get enough either.
Yeah. Well, So, perhaps because it's a disease of the elderly, but I think mainly because it's benign, and it doesn't kill you. And there are, there's joint replacement surgery, there is painkillers, and also it's a really difficult disease to study. People have been trying to find a cure for OA for years and years and years, and cartilage is a very difficult tissue to work with.
Why did you choose to do it then if it's so difficult?
Yeah, very good question. As a plastic surgeon, we see a lot of hand surgery patients actually with osteoarthritis, and although we do have good joint replacement surgery for hand OA, it certainly needs some other form of treatment. So it's very interesting once you get into it.
Let's have another question. This lady here.
Hello. I'm just a bit interested about the microbubbles. Where exactly do they come from, and do they break down in the body? Are they kind of manufactured protein or something?
The microbubbles are commercially manufactured. They're very cheap, actually. They cost about £40 for a packet.
What are they then? What are they?
They're tiny lipid shells, so fat shells. The cells in your body are actually made of a lipid lining filled by a fluid. And so the microbubbles are similarly a lipid shell with a very heavy gas inside called sulfur hexafluoride, SF6 for the chemists. It doesn't cause embolization. I know there's lots of people who are worried about injecting gas into veins and arteries. It doesn't suffer that problem and is actually incredibly safe. So what happens is when the ultrasound wave hits the bubbles, they actually vibrate at the same frequency as ultrasound, so they emit their own ultrasounds, which is why they look so bright.
Okay, so have I another question? You're determined to ask another question. I'll come to you in just a moment.
You said that the research and operations were really expensive. How's this going to affect the UK economy in the long term?
How is the expense of research going to, within the kind of
So
current
you're saying,
stage?
are you asking, is there enough money to do this sort of research?
I mean, I think that would be a relevant thing if the government was actually funding any of my research. But seeing as none of them do, and we're very fortunate to have very generous benefactors from the Royal College and also from various other charities. But my research is 100% charity funded, and that's actually a problem. I think that's actually holding back research within the UK, and I think we actually need to have more importance placed by the government on research and actually taking medical research forward so we can actually help improve the treatment of patients, which eventually one would hope would decrease the NHS burden because we'd be curing more disease.
Matthew, that's true, isn't it? Because if you put money into this sort of research that could solve these problems, it would surely save a huge amount of money.
Yeah, I mean, you saw how much osteoarthritis costs the NHS every year. I mean, it's over £1 billion. And as the baby boomers get older, the incidence of osteoarthritis is increasing. And so it's going to become an increasing burden. I mean, the number of joint replacements that happen every year is just increasing rapidly. Yeah.
And I mean, Joe, with all this effort being put into stroke prediction and reacting to these minor strokes, has that made a difference? Does that translate into savings?
I don't have the figures offhand, but I'm sure that there's a huge health economic impact of stroke. If you think that every stroke patient, there is required funding for carers, modifications to their property, the inside of their home, access issues, care within hospitals, admissions for chest infections and urine infections, bed sores, etc. However much effort has gone into treating patients with strokes, they will unfortunately suffer lots of these health problems and required to go into hospital quite frequently. It's very, very important that we're able to predict and therefore prevent strokes from happening, because it will actually impact very positively on the economy. But most importantly, it will prevent these individuals from becoming dependent on those around them and suffering the effects of having a stroke, both physically and on their personality.
I must come back to the gentleman in the middle. He's been putting his hand up all the time.
Yeah, dead keen. I was just wondering, two questions back to Joe, actually, which was, First of all, just a simple one, which is what tool do you use to actually remove the plaque?
What tools?
Yeah, is it you just scraping around?
There's a specific instrument which you slide between the area of disease and the artery wall. It's called a Watson chain, if you want to write that down.
What does it look like?
It looks like a very fine spatula, and it can find its way in between the area of disease and the normal part of the artery wall.
Brilliant. Okay. The other question is to do with, I suppose, longevity of cure, really, in that you're obviously removing this plaque, and I know your study is quite young, but maybe drawing an analogy with other studies or other parts of the body. What's the chance of plaque build-up, and at what rate? And it's sort of basically a return of the same problem. Would they need a revisit, say?
It's very unlikely that a patient who's had the surgery will need further surgery. The reason for that is when the operation is done, the artery is not closed, so it's actually not returned to the same size it was before the operation. What's done is there's a piece of material which is placed in the artery wall called a patch, and that patch makes the artery wider, and so that gives you extra time. It would require many more years of disease build-up to cause the same degree of narrowing in that widened artery than would be the case if the artery was closed normally. So by widening the artery, you're reducing the risk of a return of the narrowing quite dramatically.
That's really interesting, thank you.
Any more questions? Yes, this gentleman down here.
Nice question for Matt. Your work's looking at the generation of osteoarthritis, looking at the chondrocyte behaviour. Has your work looked into methods of regeneration of chondrocytes? So people have already got osteoarthritis, whether you can treat that rather than predicting it?
Yeah, this is one of the big issues because firstly, people thought that cartilage was pretty inert. Once it degrades, it has no chance of actually regenerating itself. So that's a big issue. Clearly, if you're an older person who presents with osteoarthritis for the first time, age 60, you may be too late to treat because there isn't much cartilage left, and the cells that are left have just no ability to repair. So this is why trying to identify biomarkers might allow us to diagnose you 20 years earlier, at which point we can try and G up the chondrocytes perhaps to produce more matrix. One thing some orthopedic surgeons have tried is actually implanting autologous chondrocytes. So you're essentially taking cells and putting them back into the cartilage. But there are all kinds of problems with that. Trying to get them to stick, in the area that needs new matrix regeneration is difficult. But I think that the way people are now looking at it is that actually chondrocytes do perhaps have a chance of regenerating cartilage. So that if you give them the right signals, then they might be able to do that. Whereas before, no chance.
Could you grow cartilage outside? Can you grow the stuff?
Yeah, you can certainly grow it. You can, sort of tissue engineering, you can have a scaffold, and if you have the right scaffold, the right cells, and the right environment, you can grow cartilage. You may have seen in the papers there was the mouse that grew an ear on its back. Did anyone see that? Yeah, well, it was a bit it didn't grow an ear. Someone implanted a scaffold that looked like an ear underneath the skin of the mouse. But what did happen was that the cells, did migrate into that scaffold, and so it did sort of regenerate cartilage. So clearly, if you had the right shape scaffold, you could then get the cells to sort of migrate into it and create a tissue of that shape.
Because at the moment, the only option really is a joint replacement. There's nothing much in between, apart from a little bit. You can do repairs or joint replacement.
Yeah, I think really joint replacement is the main surgical option, which is very successful. You do obviously have to be treated by an orthopedic surgeon, which comes with certain. Sorry, I couldn't. Most people think I'm an orthopedic surgeon, so. But no, at the moment, most of these sort of autologous chondrocyte work is experimental.
Let's take a couple more questions. You've had your hand pushed up. This just down here. You keep your hand up. Thank you.
This question is more about the biocancer. Why focus on biocancer and not on lung cancer or liver cancer?
Yeah, why this particular very specialist? It's horrible, but doesn't affect that many people.
2 reasons. One, you have to focus on something. So you have to pick something to focus on. Otherwise, if I was doing lung cancer, why lung cancer and not, liver cancer? The reason that I chose biliary cancer is because I'm interested in liver surgery, and that's what my kind of training will eventually lead me on to. And it's a very under-researched area because it kind of has been rare and has had such a dismal prognosis. People haven't really looked very well into it. So what we've got the luxury of doing is using a lot of techniques that we have available to us, which have been used in other cancers, to look at this cancer, which are well developed, and to get results quite quickly, because we're not having to, we can do things that have been done in other cancers and translate them into biliary cancer.
Okay, let's take one more question. Oh, let's take 2 more. Suddenly, loads of people want to ask questions.
One more question.
Okay, we'll take a couple more questions. This lady over here.
I'm aware there's lots of ethical reasons that run alongside research. Are your sample group aware that they are part of this research? And it's not clear whether you are going to intervene at that point. You think they may have a stroke, or whether that is going to be allowed?
All of the research we've done has been applied and awarded full research ethics approval. The initial study, the results of which was shown here today, all the patients were fully aware that they were involved in research, and actually their involvement in that research didn't actually alter the outcome at all, i.e. the ones that were going to have surgery had surgery, and the ones that weren't going to have surgery didn't have surgery, without taking into consideration the results of the scan, because obviously that's in experimental stages or in early research stages. We don't know what the results mean. We didn't know what the results meant when we were doing the scans. Those patients which are having the scans and then being followed up, again, all of them will give full written informed consent, having been counselled about this. They will only enter the study if it's been decided that they're not for surgery. So it's not that by entering the study they'll be denied an operation. They're the ones in whom, under normal circumstances, they wouldn't be offered surgery. But as we know, a proportion of those will have a stroke or a mini stroke in the future. If that does happen, they will then change from being a group which would not normally be offered surgery to then being in a group which would be offered surgery. They will then have their surgery. So it's very important that by undertaking this important research, we don't impact negatively on any individuals who are helping us with that.
So actually, in doing your research, people should be benefiting from it.
Absolutely. There's been lots and lots of research done previously on the well-being of individuals who are involved in research. People who are involved in research studies often get looked after very well. They're monitored very carefully. They have tests at regular intervals, and perhaps they have they're in a very monitored situation where their care is very well looked after.
Okay, let's have one more question. Who to choose? Just give the microphone to one of those two there. Yeah.
It's a question for Joe. Are the micromolecules broken down by enzymes, or are they filtered out of the blood by the kidney?
What happens is the microbubbles go up into the lungs, and they actually the gas gets breathed out of the lungs. So there's no significant remnants of the microbubbles at any stage after their injection, after a few days.
I think we're all fascinated by these microbubbles. Okay, well, thank you very much to our 3 people here, Matthew and Siobhan and Joe.
thank you for sticking with us. We hope you've enjoyed yourselves this evening. I've certainly found this absolutely fascinating, and it starts to make sense of all the photographs that I see on the wall on a regular basis outside this lecture theatre of the other surgical research fellows. If you would like to tell us what you thought, good or bad, we do have an evaluation form that was left on your seats. We do read them, we do take notice of them. You'll notice a nice, cool environment that we have here tonight. From feedback in the past that's told us this room gets too hot when it's very full. And we even type them up, and we do statistical research, though possibly not quite as in-depth with fewer graphs than what we've seen here today. There is also, if you're interested to know more about the research work that goes on here, there are the blue leaflets. And I can never miss up this opportunity to have a crowd of people to plug our next event, which is going to take place this Saturday. Something completely different, as they say. It's the big draw, which is going on throughout the whole of October. So if you have any artistic inclinations, come along and get some expert tuition from the Medical Artists Association and from the House of Illustration. So you're welcome to come between 12 and 4. It's free, as this evening, and we'll provide you with all the materials you need. We'll hope to see you again. Thank you.